Welcome back to my channel, folks. Today we have an important topic to discuss that can affect people of all ages. Imagine suddenly experiencing sharp and stabbing pain in your flank region. That's what our patient is going through. We'll be exploring the case of a 42-year-old office manager who presents with severe right flank pain. Let's dive into it and understand more about renal colic and how it can be managed effectively. A 42-year-old male office manager has come to the GPA practice with severe pain in his right flank region. The pain started suddenly about 6 hours ago and has been increasing in intensity. He describes it as sharp and stabbing, radiating from his back towards the lower abdomen. Additionally, he's been feeling nauseous and has experienced occasional vomiting since the pain started. The patient denies any recent history of trauma or injury to the area. The patient's medical history and lifestyle may provide some clues. Let's take a look. Past medical history to look for gout, hyperparathyroidism, renal tubular acidosis, osteoporosis, and recurrent urinary tract infections. Medication history if he is taking loop diuretics, carbonic anhydrase inhibitors, ciprofloxacin, sulfonamide, containing medications, and indinavir. Ask diet to check for dehydration, high salt, and protein intake. It's essential to conduct a systemic review to gather more information. Some key areas to explore include associated complaints, systemic review to rule out other differential diagnosis like pyelonephritis, which typically presents with pyorrhea, fevers, chills, and flank pain, intestinal-associated diseases, including obstruction, appendicitis, and diverticulitis. Add ovarian cyst torsion, ectopic pregnancies in female patients. Medication history. Diet habit. Occupation history to check if the patient is a military or an airline pilot. Urine dipstick may detect blood. Hematuria is present in roughly 85% of renal colic cases. Midstream urine culture, microscopy, and sensitivity. Full blood count, serum creatinine, electrolytes, serum urate, serum calcium, serum phosphate, C-reactive protein, beta-HCG. Computed tomography, CT, and X-rays of the kidneys, ureters, and bladder, KUB, should be ordered and performed on the same day. Ultrasonography may be useful in patients in whom avoiding radiation is necessary. Example, young people, women who are pregnant. Let's focus on the immediate management now. Diclofenac 75 mg 3 ml, injection intramuscular repeated once, may be given 30 minutes later if required in the opposite side. Morphine 2.5 to 5 mg IV statum, then titrate to effect, or fentanyl 50 to 100 microgram IV, then titrate to effect. Avoid high fluid intake as it provokes distension of ureter and aggravates pain. If in doubt, especially if narcotic addiction is suspected, an appropriate agent would be ketorolac toradol, 10-30 mg intramuscular. Prescribe the patient diclofenac 50 mg orally 3 times a day for 1 week. Tamsulosin 400 microgram until expulsion of stone. Dietary advice to prevent recurrence of renal stone. Good hydration is key to stone prevention. Advise patient to drink to a level where the urine produced is clear. Calcium is a risk factor for renal colic. Misconception. Studies have shown that a normal dietary calcium can reduce the risk of calcium stone formation compared with a low calcium diet. Dietary sodium causes increased urinary calcium excretion by reducing calcium reabsorption from urine. Therefore, a low-sodium diet can be beneficial for patients with recurrent stone. Low oxalate diets have been shown to help peanuts, rhubarb, spinach, beets, chocolate, and sweet potatoes. A low-protein diet can help reduce recurrence of urolithiasis. Follow-up scans should be organized 4 weeks after the initial visit unless a stone has been collected and verified. Refer the patient to surgery in case if the patient with evidence of complete urinary obstruction, patient with a single kidney, that is congenitally, postoperatively, bilateral obstructive stones or anuria, patients with minimal renal reserve, patient with pre-existing kidney disease, occupational need to be stone-free, example airline pilot, military, refer to emergency in case of fever or other features, e.g. rigors, consistent with systemic infection, which can lead to life-threatening sepsis. Pregnancy, renal colic during pregnancy. Refer to urologist in case of stones greater than 5 mm. Patients who have been trialing conservative management for 3 weeks and have not passed their stone. ongoing pain despite adequate oral analgesia. Patients who have passed stones but have ongoing blood in the urine, preferably with 3 urine cytology tests and ACT intravenous pyelogram. Type 2 diabetes mellitus. Staghorn calculus. Other treatment options: extracorporeal shockwave lithotripsy, 5 to 10 mm, laser lithotrips, less than 20 mm, percutaneous nephrolithotomy. Some extra advice in case a patient comes to the general practice after stone surgery. Stent-related symptoms: hematuria, dysuria, and increased urinary frequency with a constant feeling of urgency. Don't concern unless it is causing urinary retention or urine culture positive. Fever or persistent and severe flank pain are not to be expected, and in their presence, a UT or stent misplacement or migration should be suspected. Tamsulosin and anticholinergic medications can help with the urinary symptoms.
Hey guys, please like, share, and subscribe, and do hit the like button for more updates like this.